Thank you, Mr. Chairman, dear colleagues. First, thanks to the Society for inviting me to this session. And first, I would like to say that our very classical perception of septic shock is the one of an overwhelming inflammatory response, sometimes leading to early death. But this very typical clinical course is now often challenged by more blunted presentations in patients who became highly susceptible to nosocomial infections due to low virulent pathogens such as opportunistic bacteria and fungi and viruses. And these patients are patients who survived the primary aggression, such as patients with septic shock, but also patients with other non-infectious insults, and also patients who may have this blunted presentation right away because of chronic illnesses such as immune and non-immune comorbidities. And this clinical course have changed our perception of sepsis-related death. Some people, as I said, will die very early from overwhelming inflammatory response. But nowadays, thanks to advances in the management of septic shock and multiple organ failure, most patients survived the early days in the intensive care and will die later on. Some patients will die later due to intractable inflammation-induced organ injury, and some patients may present late complications related to immunosuppression and an increased susceptibility to ICU-acquired infections, but also, and it has to be mentioned, that some patients may also display some non-infectious complications such as major bleeding and ischemic complications. And this is exactly what we observed in this study that was performed in our center in more than 500 patients who presented septic shock during the early 2 days in the intensive care unit. The overall in-ICU mortality rate was about 37%, and you can see that only 1/3 of death occurred during the first 3 days, while the remaining death occurred later on. And when we analyzed the causes of death, the main diagnosis leading to death in those patients who died early died from multiple organ dysfunction. That was not a surprise. But for patients who died later on, you can see that the major cause of death was doing nothing, I mean the end-of-life decisions, but in patients for whom a comprehensive diagnostic workup could be performed, the main cause of death was ICU-acquired infection, but also other causes of death were related to sustained inflammatory disorders such as mesenteric ischemia and primary infection-related multiple organ failure and ARDS. And we know from several studies, including this recent one from the Mars consortium, that ICU-acquired infection have a high burden in the intensive care unit. And you can see from this study that the incidence of ICU-acquired infection in patients treated for severe sepsis had an incidence of about 13%. It was associated with an increased in-hospital mortality rate with an attributable mortality fraction of about 11%. And another complication that is frequently encountered in septic shock patients is the reactivation of latent viruses, including cytomegalovirus and herpes simplex virus. About 25% of patients with septic shock will exhibit a reactivation of the cytomegalovirus, and about 15% will exhibit a reactivation of the herpes simplex virus. And what is fascinating is that the reactivation of those herpes viruses is associated with an increased incidence of fungal and bacterial infection in the intensive care unit. Is it only an association, as the reactivation of viruses may represent a marker of immunosuppression, maybe, but what is interesting is that those viruses have immunomodulatory properties, and it is particularly true for the cytomegalovirus, which is able to impact on the main functions of antigen-presenting cells, for example. And we know from other other clinical settings that the reactivation of cytomegalovirus might favor the development of opportunistic infections, such as invasive aspergillosis, for example, in bone marrow transplant recipients. So we have quite a clear clinical phenotype of sepsis-induced immunosuppression, and I would say more generally of post-aggressive immunosuppression. And this clinical phenotype is underlaid by multiple defects in immune cells, including innate immune cells and adaptive immune cells. For example, we know that dendritic cells undergo fast apoptosis following sepsis, and the remaining dendritic cells display impaired maturation capacities. We know that monocytes and macrophages display major functional abnormalities, also called deactivation. The two main features are a decreased expression of the antigen presentation apparel and a decreased production of pro-inflammatory cytokines when challenged ex vivo with microbial products. We also know that lymphocytes undergo apoptosis within secondary lymphoid organs, and this apoptosis is some of these cells may be relatively spared from apoptosis, including the T regulatory cells with immunosuppressive properties. And altogether, all these quantitative and functional defects in immune cells lead to strong alterations in the immune synapse. And in sepsis, the three signals of the immune synapse are impaired. There's a decrease in the expression of the antigen presentation apparel at the surface of antigen-presenting cells. There's a decrease in the expression of co-stimulatory molecules, while an increase in the expression of co-inhibitory molecules, such as the PD-1, PD-L1-2 partners. And there is also an alteration in the third signal, which is an aberrant production of cytokines, the immunosuppressive IL-10 being produced rather than the immunostimulant IL-12. This results in an anergic and regulatory immunosuppressive response at the lymphocyte level. And this is quite a complex picture obtained from clinical data, obtained from experimental animal models. But what is interesting is that we now have some relevant biomarkers in critically ill septic patients, reliable biomarkers that have been obtained through such studies. And all these studies have quite the same methodology and also the same limits. Nearly all are monocenter study, some various inclusion criteria, but basically sepsis and severe sepsis. A major exclusion criteria is that all patients with any prior immunosuppression have been excluded from such studies. There are various measurements, but all based on blood samples, so on immune circulating cells. The endpoints are mortality, and more recently, the development of nosocomial infection, and the small sizes of this cohort preclude any relevant statistical adjustment. But anyway, such studies have allowed to provide us some reliable biomarkers that may predict the vital status, the in ICU or in hospital mortality, but also the development of ICU acquired infection. For example, the lymphopenia, you know that all septic patients become rapidly lymphocytopenic, and the absence of recovery of lymphocyte count, the severe persistent lymphopenia, is associated with an increased mortality rate, but also with an increased incidence of ICU-acquired infection. But so far, as of today, the most robust biomarker of sepsis-induced immune suppression is the deactivation of monocytes, as assessed by the low expression of the HLA-DR, which can be easily obtained now at the bedside with the help of immunology or hematology laboratory, and it is now very easy to quantify quite precisely the number of HLA-DR receptors at the surface of monocytes, and you can see on this picture that Professor Guillaume Monret-Lyon lent me, that monocytes from septic patients exhibit low expressions of HLA-DR. And Guillaume Monret showed in 2008 that it was a strong, the persistence of deactivation of monocytes was a strong predictor of vital outcome, and patients with persistent monocyte deactivation had increased hospital mortality. And in 2010, it showed that the persistence of monocyte deactivation was an independent predictor of the development of ICU-acquired infection after adjustment on the baseline severity and the requirement for invasive procedures such as mechanical ventilation and intravenous catheters. And we can also monitor the expression of co-inhibitory molecule at the surface of circulating monocytes and lymphocytes. It was also a work by Guillaume Monret's team in Lyon. And so we have some quite relevant biomarkers of sepsis-induced immune suppression, and this immune alteration can now be targeted by some drugs in order to restore the functions of those immune cells. For instance, the Interferon-gamma and GM-CSF are able to target the deactivation of monocytes and macrophages. We have some anti-PD-1 and anti-PD-L1 specific antibodies that were primarily used in cancer treatment, but can be used to restore the functionality of the immune synapse. And we have a cytokine called IL-7, which is able to restore a proliferation and an activation of lymphocytes. And some of these, all these compounds are actually evaluated in ongoing clinical trials, but some results have already been published. For example, this German study in which 38 septic patients were randomized to receive either GM-CSF or placebo on the basis of the deactivation of monocytes. So this treatment was very efficient to restore normal activation of monocytes with an increased expression of HLA-DR and a restored production of TNF-alpha in response to ex vivo stimulation by lipopolysaccharides. In terms of clinical endpoints, there was no difference in the mortality rate, and the only clinical endpoint that was different between the two arms was a shorter time on ventilator in patients who received GM-CSF, but with the limit that there was no winning protocol in the study, and that we do not have the incidence of ICU-acquired complication, and particularly the incidence of ventilator of hospital-acquired pneumonia in this study. But this result, the time on ventilator, beyond a result of overall mortality, is probably very relevant now. Interferon-gamma has been assessed in the treatment of invasive fungal infection, and you can see that interferon-gamma has the same effect as GM-CSF, as it is able to restore an expression of HLA-DR expression on monocyte surfaces, and it is also able to restore the sensitivity toward a stimulation by Candida albicans. And finally, there is now the possibility to target different immune defects, and it has been nicely shown in this case report published by my friend David Grimaldi and Auterman, recently published in the Lancet Infectious Disease, in which a young patient from the terror attacks in Brussels in March developed gastric and splenic mucormycosis, which was treated as it should be, I mean with surgery, which could not be complete because there was invasion of adjacent structures, and antifungal therapy. It was a combination of liposomal amphotericin B and posaconazole. And these patients received a combination immunotherapy with nivolumab, an antibody against PDN1, and interferon-gamma. And she finally recovered. And some would argue, well, it's only a case report. I say, yes, it is a case report. But it is a very good example of personalized medicine in a very severe patient beyond protocolized medicine. And personalized medicine in severe patients, it's what we are trying to do every day at the bedside for those patients. So what are the limits to a larger implementation of immunostimulation in those patients in the post-septic phase? First, is sepsis-induced immune suppression really harmful? I mean, ICU-acquired infections are very heterogeneous and have different pathophysiology. I do not think that we can compare a post-surgical complication with a recurrent ventilator-associated pneumonia, for example. There is a low attributable mortality of ICU-acquired infection, and probably we have to move to other endpoints than mortality. Some patients may die from non-infectious ICU-acquired complications. And we have learned from other situations in medicine, and particularly in critical care medicine, that the murine models on which we base this concept are finally not very relevant to the human pathology, because we are using young and non-comorbid mice while we are treated aged and comorbid patients. And we are, the infectious insults are non-physiological because, for example, we inject massive loads of bacteria. And a major problem also is the currently available biomarkers, because we have to know what we are measuring with these biomarkers. There is a compartmentalization of the inflammatory response, and we are currently at the bedside only able to measure the behavior of circulating immune cell, which can be quite different of that of immune cell resident in tissues. And we know also that treating patients with immunostimulating drug can be harmful in patients with persistent inflammations within organs. So finally, what can we do as of today at the bedside? First, this is a concept developed in non-immunocompromised hosts that presumably applies to the immunocompromised, but we have no clinical data so far to support this. What should be our relevant endpoint? Should it be mortality or other relevant endpoints, such as the duration of mechanical ventilation, for example, or duration under vasopressor, or the length of stay in the ICU or in the hospital, which are also relevant endpoints. Which interventions? Well, we are today doing some interventions to prevent the development of ICU-acquired infection by controlling the exposure to other risk factors, by restricting the use of therapeutics with known immunomodulatory potential, such as, for example, transfusions, corticosteroids. We know that it's possible now to perform accurate immunomonitoring in patients, and we'll have the possibility of immune-enhancing treatments, but I think we should wait for more results from the ongoing clinical trials, and also maybe the preemptive treatment of herpes viruses reactivation could be a way to decrease the risk of ICU-acquired infection. Thank you very much.